Welcome, everyone. I'm honored to be facilitating this session on new advances in colorectal cancer treatment. Having facilitated this conference in the past, I can tell you that this session consistently is one of them that has the highest level of interest based on what we're going to talk about today. We're in a time of rapid progress in colorectal cancer care, from cutting-edge immunotherapies and precision diagnostics to new surgical techniques and more coordinated models of care. Today's panel brings together leading experts to share latest developments that are changing how colorectal cancer is treated and experienced. This session is very much about looking forward at some of the breakthroughs in improving survival and quality of life, and the ongoing work to ensure that patients can access these new innovations. So let's get started. I'd like to welcome Dr. Navdeep Dahar, who is a GI medical oncologist and an assistant professor of oncology at the Arthur Child Comprehensive Cancer Center at the University of Calgary. I'd also like to welcome Dr. Sunil Patel, who is a fellowship-trained colorectal surgeon at Kingston Health Sciences Center. He has specialized training in minimally invasive surgery, including robotics and laparoscopic surgery. He specializes in treating rectal cancer, colon cancer, inflammatory bowel disease, and diverticulitis disease. And lastly, I'd like to welcome Soying Kim, who's a patient advocate and works currently as the head of product at the Center for Infectious Disease Genomics and One Health at Simon Fraser University. Welcome to all of you, and thank you so much for being with us today. Dr. Dahar, I'd like to start with you to kick things off, to talk about your work, what is standard of care today in colorectal cancer care in general, and where you see some of the new treatments evolving to.
Hello, everyone. Thank you so very much for inviting me to this platform. It is my first time working with colorectal cancer for this community conference. So I'm really excited. I'm looking forward to some great discussions today, and then we hope learn from each other. So I've been asked to kickstart this session, which is basically tailored to the precision medicine testing, access, and how we utilize this in the diagnosis and management of colorectal cancer. So basically, in this particular topic discussion, I think we are going to talk about a lot of complicated terms. And I would like to just take maybe 1 minute to give a sort of a introduction to this topic. So we talk about precision medicine in many different ways. So at the core, it just really means that we are personalizing the treatment of any kind of cancer to the patient's own tumor type, the characteristics which we find after we do special testing, which is known as next-gen sequencing. It really allows us to read and analyze the DNA or even the RNA sometimes in a timely fashion to sort of give us the baseline genetic information about that tumor. What kind of characteristics it carries, and some of the things that patients might find on their reports are microsatellite instability, which is basically a molecular marker of a defective DNA that will be found on this next-gen sequencing test. And there will be terms like mismatch repair deficiency, which is basically a deficiency of one of the mismatch repair genes, which is expressed on its surface as a lack of one of those proteins, which that gene is known to do. It expresses the protein on the surface. So if those things are there, there are implications to how we approach those tumors in terms of their just at the presentation or even like the subsequent choice of therapy. And usually these would be discussed with the patient. And I'm going to go into details in a little bit. So coming back to the next-gen sequencing, as I explained, we're looking at the number of defects at the level of tumor DNA. Some of the other things besides this MSI, MMR, you'll also see the mutations, just like if there is a KRAS, NRAS, BRAF, all these terms, like these are just the letters which are mentioned in those reports, whether those mutations were detected or not. And at different stages of the colorectal cancer management, we use this information to inform the choices of the therapies which we can recommend to our patients. So this session, we're going to talk a lot about access challenges and things like that. But really, at this time, if I were to talk about the current standard, so for the colorectal cancer, once a patient is diagnosed with this condition, then there is a reflex testing that is available at the time of diagnosis, which does not include a lot of information which I just mentioned, but it would contain the MMR testing results. And that is done on all stages 1 to 4 of the colorectal cancer diagnosis. So any patient who gets this diagnosis will get MMR testing reported upfront. Further testing is only performed for metastatic or stage 4 disease, and that is usually upon the request of an oncologist. And the existing panel will include the tests which I just briefly introduced you to, the KRAS, NRAS, BRAF, and PIK3CA, which is often kind of reported, but so far is not being used. So, and this is initiated by the oncologist upon the receipt of the referral to a cancer center. And results are generally available at the time of the when the patient meets the oncologist, or sometimes we have to wait. There's a lot of discrepancy in when these tests are reported. In addition, one more test, we call it as NTRK fusion, and that can also be requested in cases where we see the late stage or resistant disease, where this target for this particular mutation, the drug is available for any tumor type. So this information can be used rarely. So that would be sort of the current standard at this time with respect to the precision oncology tests.
Could I ask a couple of questions about that for clarity, Dr. Hart? Thank you so much for using a lot of lay terms around this language too, because it's terribly confusing, as you can imagine. So this is all standard of care? And if you've just been diagnosed, so to speak, like how do you know which test goes where? How do you know which test to ask for? Or does this vary based on who your oncologist is?
So, as I mentioned, the MMR testing is one aspect of the precision medicine test that at this stage is available to all patients who are diagnosed regardless of the stage. And this is at the time of the diagnosis. So this is the standard protocol, which the labs know once the patient is diagnosed with the colorectal cancer, they would automatically subject their sample to this testing. And this is reported at the time of diagnosis even. Sometimes the report will say that we'll release an addendum, but it usually is available pretty quickly. The other tests are usually like we have to ask them. At my center, we have our coordinators who sort of triage the referrals, and they are able to see that, okay, this is a stage 4 colon cancer, and my doctor is going to eventually order. So we have directions to let them, order it on our behalf so that it saves time. But we have to make it on our own. And that is the question regarding how do we know? that is a standard sort of, they run a 50 gene panel, like mass array testing. It does not give you a whole bunch of tests, like you could say, they will only report for the mutations where targeted drugs are available. So that is sort of the standard. It's only available for the mutations for which the drugs are available.
Right. So if I am a patient who is facing a cancer diagnosis, how do I know what to ask for? Or how do I empower myself to know what to ask for? Or is it totally in the hands of the oncologist?
That's a very excellent question. And I think here is the role of awareness, like patient awareness, and even like the specialist awareness of discussing, and on the patient front, asking the question to their specialist when they have their first meeting, that what other kinds of treatments are available. I am aware that there are precision testing available in the form of next-gen sequencing. If they cannot even use that name, if you sort of start the discussion by asking that, are there any targeted therapies available? Or can I get the immunotherapy? That sort of tells your physician that, yes, this patient seems to have done a bit of homework, or this is the right time to sort of initiate that conversation. So being MMR being the standard of care right now, I personally have adopted this practice that I will print the report and take it to my patient whenever I am seeing them for the first time, and I go line by line that this is what your diagnosis is, this is what it means, and their MMR is always reported. And right there, it is my opportunity to tell them that what it means and how it will affect your prognosis, or even predict the response to some of the treatments which are offered in the early stage. For example, if a patient is MMR deficient and has a stage 2 disease, then in that case, we know that it has a prognostic value that these tumors tend to do very well and do not need to get adjuvant treatment with chemotherapy. However, and in addition, the research has shown that if you use 5-FU based, which is one of the kinds of chemotherapy agents we use for colon cancer, it's 5-fluorouracil. The studies have shown that these people do not do well. Plus, this chemotherapy is not as effective if they have MMR deficient disease in stage 2, right? So, and that sort of gives gives the specialist or myself a chance to discuss that if this were to be the case, then you could have avoided the chemotherapy. So, and it all depends on each individual physician's practice. I just shared that I like to inform my patients up front. And this also gives you the opportunity that if at all this cancer comes back later on, because you also have to tell them that once you're a cancer patient, you're on surveillance, there is a tendency, some fraction of people can see recurrences, and then it's usually stage 4, and a different set of tests are conducted, which we use to choose the treatments at that time.
Right. Thank you so much for that detailed explanation. So, I want to bring you into this conversation because it's a lot. Mm-hmm. It's complex, and we're so fortunate to have in this country amazing oncologists to help us with this. But as a patient, what was your experience in going through some of these tasks, figuring out what treatment was right for you, particularly in the context of what we've just heard? Soyin, may I ask, are you with us?
I am. Can you hear me?
Yes. Hello.
Okay. Perfect. So I'll like to provide the perspective. I guess this is sort of my professional experience, as well as the experiencing cancer as a patient. So I was diagnosed with stage 3 rectal cancer in March of 2022. And I have received chemo and radiations, and there's a lot of consultation and testing that had to be done. Well, it's one size fits all, standard as a standard of care for cancer. So it is comprised of multiple rounds of chemotherapy and radiation. First of all, I like to point out that it's excruciating for someone who have gone through it. So I empathize with everyone who currently goes through it. So for me, I mean, many others, the injections result in neuropathy, open sores, massive weight loss, vomiting, and perpetual nausea. So there's 100% toxicity right there. And, often for a smaller than 48% chance of efficacy. So, you could think of it as a coin flip. So in terms of treatment option, I think it's very important to do a genomic profiling upfront, and not only to guide the initial treatment. So, chemotherapy as first line of treatment, but I feel that the genotypic profiling and characterizing your tumor and which mutation you have, etc. It's very important over the lifetime. So managing things like after chemo, and if you're looking at non-operative management, you're thinking about, not getting surgery, or maybe you're thinking about perhaps something like aspirin will work for you in terms of ongoing management of your cancer. So since as someone who's kind of gone through the initial rounds of treatment, radiations, chemo as a standard of care, and cancer is just not one and done thing. It's a multi-year, it's a lifetime management, and I experienced many places where this upfront genomic profiling and more information, not just the MMR microsatellite deficiency testing, but the need for more granular characterization of the tumor and understanding of the mutation and the type of cancer that I do have. And I believe it has a life cycle long impact to guide various treatment that I need throughout my cancer journey.
So, Sayan, did you actually have one of these types of tests at the very beginning of your journey?
It's actually funny you ask. So I used to joke with my friends and family that my cancer is living its best life, traveling to places I always hope to visit. So I ended
up attitude, I have to say.
I ended up working with the multiple providers across multiple continents. So, here in Canada, as well as South Korea, and in US, both in Oregon, as well as Boston, like Dana-Farber. So after consulting with colleagues and the US Genomics Conference, I was, working with the multiple providers, got lots of referral, and sending my pathology samples everywhere. So essentially slicing and dicing my tumor. So they've been sent to internationally for various analysis. In many cases, because there's so many people involved, so many processes. And yes, I did try to get this test and then get my tumor characterized because I wasn't eligible in Canada, working with my primary care providers, my oncologists and radiologists and so on here. But I ended up in a situation where I ran out of specimen, for example. So, if after all that investment, traveling and securing an oncologist in a foreign country, etc., and then this was all during the pandemic. So you can imagine, getting on the plane and with the mask on, and, there might be some complication because of you traveling. So after all of that, and, some of the test results turned out to be inconclusive. So lack of nucleic acids. So there's some frustrating moments like that in terms of working with many providers, and especially in the context of try to get access to some of this genomic testing as emerging and new innovation.
Thank you very much. And I want to come back to that. So, Dr. Patel, I want to bring you to the conversation in a moment, but I want to close off with you, Dr. Dhar, because again, I go back to the point, it's complex. And I've understood that you have some kind of infographic that you're developing to help standardize diagnostic testing, to help a person who've just been diagnosed to know step 1, step 2, step 3, what's best for them If you could just articulate that, that would be really helpful.
Yes, this is a study which is in the form of a survey, which I have developed with the team of actually Colorectal Cancer Canada, along with Dr. Barry Stein.
Barry Stein, who's the
Barry
president
Stein,
of,
and then there
of
is
the
one.
organization, yeah.
Yeah, and then one more patient organization from out of Belgium, and they run this FT3 program, which is from testing to targeted therapies. They have a focus on improving the access of precision medicine tests in their area, like in Europe. So what we have together done is that FT3 had this. The adaptable patient education resources, which we used. And I have been able to design specific documents pertaining to different tumor sites, which give patients very initial basic information that they should know at the time of their diagnosis. So it starts off with giving them a bit of like introduction when they say colon adenocarcinoma, like what cancer is, how it develops, what are genes, and then what is precision medicine testing, what is next gen sequencing. But these terms are just kind of very basic grassroots information. And then we have pictures included, and so those like the educational documents also talk about different stages. It gives them information how we stage this cancer. And then what are the initial pieces of information, which I briefly mentioned already, how they are utilized in decision making, what are the questions that patients could ask their physicians. It also talks about that. And do they feel that at the end of this, like reading, was it helpful? Did their, so this educational document, once they read, they sort of are like asked to answer a set of questions to get some feedback whether it was really helpful. So far, I think it has, given us really good feedback. I've been able to distribute it to quite a few patients in my clinic. I'm covering colorectal, pancreas, cholangio, upper GI. We've also diversified into the GU space, where a lot of like renal and bladder cancers are also using the similar testing. So it is a good infographic document, which a patient can very well reach out to if things are not clear or they have further questions after having consultation with their oncologist.
Thank you. Sounds like an excellent resource, and we'll ensure that through Colorectal Cancer Canada, that resource is shared and made available. So I just want to close this conversation on testing to fundamentally, the message I think we want to leave here is that various different testing options are available. As a patient, one should educate themselves on these various different, let's call it pathways, even though there's barriers. Initiate the conversation with an oncologist who is well-versed and is very, very capable of choosing what I call the right path. Is that a fair summary, simplistically, for folks?
I think so. Yeah.
Great. Dr. Patel, thank you so much for your patience and allowing us to maneuver through some very, big conversation. I want to move now into advancements in colorectal cancer treatment from a surgical perspective. If you could paint a picture of what's today, where the future of surgery is evolving to, and what we can expect, that would be incredibly helpful.
Yeah, and thank you for the opportunity to speak today. I would like to reiterate that patients with a new diagnosis of colorectal cancer, often the first specialist they see is a surgeon. So you don't need to save those questions about testing and next steps for your oncologist, which might be the next person you see after a surgeon. So I think most surgeons don't have the same type of familiarity as someone like Dr. Dahar, but we are well versed and have colleagues that work with us all the time that we can certainly provide information for. In terms of surgery, I think there's a couple different things that are really changing the landscape of how we treat patients with colorectal cancer. I would reiterate that colon cancer and rectal cancer, although grouped together and are in the name of this organization together, are often treated quite differently. We heard from Soyin that she had rectal cancer, which often requires chemotherapy and radiation before surgery, whereas colon cancer, often surgery is the first treatment, especially for those that have stage 1, 2, or 3 cancer, i.e. the cancers that have not spread elsewhere beyond the colon or the rectum. In terms of the advancements that we're seeing right now, there's a lot of advancements in how we treat rectal cancer. And I think it's been basically a revolution up over the last 10 years, and certainly over the last 4 or 5 years in Canada. What's really changed is not that we've invented new drugs necessarily or have new treatments, but it's the sequencing of treatments and understanding that patients can respond very well to these treatments. In rectal cancer, patients are often offered chemotherapy and radiation therapy before surgery. And going back many decades now, we've often recognized that sometimes we take these patients to surgery and there's no cancer left in the specimen. It's completely been treated with the chemotherapy and radiation alone. And we wonder, why are we operating on this patient? We're putting them through the morbidity, the stress, the trauma of surgery, and to what end if someone doesn't have any residual cancer? And that's really been the big revolution in rectal cancer treatment, is trying to provide patients with the opportunity to avoid the morbidity of surgery. That's called non-operative management, which was alluded to before. Often patients receive radiation and all their chemotherapy that they're going to get before we make a decision for surgery. In about 30 to 50% of patients, they'll have such a good response that we think we can safely avoid an operation and monitor them pretty intensely with CT scans, MRIs, and colonoscopy to make sure that the cancer doesn't regrow. And if it does regrow, we can offer them surgery with the aim for cure. That's available, as I mentioned, to about 30 to 50% of patients. The other thing that I'm keenly interested in, and we've heard a lot about in the oncology sphere, is trying to reduce some of the toxicities of our treatments. We already heard today that 100% risk of toxicity, which doesn't sound very good for someone with a new diagnosis. And so what we've had a lot of interest in is can we de-escalate some of our therapies? How can we select patients that really will benefit from radiation? And how can we select patients that maybe radiation isn't an important part of their treatment? We can avoid the toxicities and the complications of radiation, similar to how we try to avoid the complications and morbidity of surgery. Same thing with chemotherapy. We know that there's some patients that really will benefit from chemotherapy and some patients that may not benefit as much. And so there's been a lot of movement on that sphere, is trying to de-escalate treatment, try to avoid one of the major pillars of our colorectal cancer treatments, to try to reduce the risks to patients, especially in the long term. And it's something that we're keenly aware of, that those that undergo colon cancer and rectal cancer surgery, they have a lifetime of functional changes. They could be left with a permanent colostomy or ostomy bag, and they could have major issues with function, such as incontinence or really debilitating bowel function changes. So something that we're keenly aware of. Another sphere that really has changed over the last 10 to 15 years is the use of minimally invasive surgery. Minimally invasive surgery is, some people call it keyhole surgery. The classic description is laparoscopic surgery. A lot of people have familiarity with this type of surgery because it's done for appendicitis, for gallbladder disease, hysterectomy, and colon and rectal cancer. Over the last 4 or 5 years in Canada, we started to adopt what's called robotic surgery, which is basically a more sophisticated and advanced version of minimally invasive surgery. And the entire point of all these, of minimally invasive surgery, is really to reduce the trauma and risks of surgery to patients, get them through the recovery and home as quick as they can, and back to their regular life. We've noticed with the adoption of advanced minimally invasive surgery, at least in our hospital, we can reduce the length of stay in hospital from about 7 to 10 days down to 1 or 2 days, which is a huge impact on patients. And I think, you think of that as a 4 or 5 day difference, but really what it means is back to normal activity within 2 to 3 weeks versus 2 to 3 months. And I think, especially as someone that may be looking towards chemotherapy after surgery, get back recovered and get back to your normal function and health is really important for us. And so minimally invasive surgery is something that's not been adopted as widely in Canada as has been in elsewhere, like the United States or in some parts of Europe. And it's something that we're really trying to push forward. We really want to get people through their surgical part of treatments with as least amount of comorbidities and complications as we can, and get them back to a functional state that they're quite happy with. We recognize, well, no one wants to be in the hospital. No one wants to be constantly back and forth to our clinics. So we really want to make sure that they get through things smoothly. So those are two kind of areas that we're really interested in.
Yeah, thank you so much for that. Such a comprehensive overview. So I process this as we're trying to do less surgery.
Less traumatic surgery, try to avoid surgery, try to avoid parts of the treatments, because we just know that it's really hard for patients to go through these things. And I think Dr. Dahar and I have worked together in the past to tell someone that they have to go through 3 or 6 months of chemotherapy can be very daunting. And if we can avoid that in some good acting cancers, I think that's really important. That's 3 to 6 months of time that a patient has back with their family, their friends, getting back to work, doing the things that they want to do, and not having to come in and out of hospital all the time feeling awful.
Yeah, thank you so much. And I love that the two of you have worked together. So, I think this is a perfect opportunity for you to bring your experience into the table. And there's big words around in the healthcare system. It's called interoperability. And I even have a hard time saying that language. What that really means is that the how care teams are communicating with each other to make these decisions on treatments. I would love to hear you talk about your personal experience around this, and an example of where you think it can work super well, and maybe an example where things fell off the rails in terms of the management of a number of experts all focused on the best care for an individual like yourself.
Yes, interoperability is a very timely topic, especially in the context of discussing innovation and new advancement. I think they go together. So from personal experiences, interoperability of the different systems and processes and the people, this is a very common topic for many patients like myself. And you can think about the tumor board, or if you're lucky enough to get your tumor characterized, molecular tumor board, and then you see this coordination between your surgeons and oncologists and family doctors, etc. And in my case, I just added more people, processes, and technologies on top of that. So when you can access genomic testing, first of all, access to innovation itself isn't enough. So if you're lucky enough to get second opinion done elsewhere, and then how are you going to actually use that information to communicate with your own primary care providers, right? So that information and insight need to be shared among your care providers for it to be meaningful and helpful for you for the purposes of designing your care. And I talked about this, the specimen, and you get a biopsy at one hospital and how that can be shared. Either the specimen itself can be shared, or perhaps there's a whole genome sequencing done in a particular location, and that data can be shared with other providers who might be running different tests or bioinformatics processes to really understand the type of cancer that you have and mutation you have better. So from an interoperability perspective, I think it's really key that and not only you have the ability to access innovation and then tap into new advances, but how to interpret the finding from genomic testing to who's going to be actually using that information to make what type of decision. I think that's also very important. So I see the interoperability go hand in hand with new advancement, especially approaching innovations. Interoperability happens to be a very difficult topic, as it involves not only people's and also processes and various technology across many different organizations. So that's something that I've experienced firsthand, as I mentioned, working with oncologists across multiple continents. So you can imagine it just blows up, right? In terms of its challenges.
So do you mind if I probe in on that with you? Because I think this is so important for folks. You have an extraordinarily, let's call it scientific and technical background, and are able to do this. Were you your own quarterback around this? Or who was managing all of this? How did that look? If I'm an average person who is facing, a lot of different appointments with amazing oncologists and surgical teams, et cetera, how am I keeping track of that? How am I knowing that people are coordinating themselves? Did you do that for yourself? Or what should people expect?
The interoperability side of things, especially if you're bringing data or processes or test results from external organizations and then try to use that within your own primary care setting in Canada, it's not well done. It's a huge challenge at this point in time. And I rely on many of my personal contact in terms of, finding out what innovation exists elsewhere. So things like the targeted panel, which is a bit different from whole genome sequencing. It's targeting a specific well-known gene mutations, and that's a standard of care very much in U.S. hospital, whereas we do not have that here. So try to access that, and things like some of the clinical trial information, who's doing what. So for me, non-operative management is a very important point for someone who's young, and then try to be are there opportunity to avoid surgery, as Dr. Patel just mentioned. So there's a lot of information I have to get through my own personal networks and then leveraging some of the work connections. But it's really challenging. So I would say that
challenging. Yeah.
most challenging aspect of advocating for such change, so in this case, I'm advocating for myself, fighting to increase my odds at survival, is this feeling of helplessness and lack of agency sometimes. Data sharing is very difficult. And then you're moving through the system as if I'm a passive package, where critical decisions regarding my own survival are made for me and not with me. So a lot of this information, or maybe perhaps the insight that is shared at the tumor board, they're not communicated to me. But, I'm the one who's actually going through this, but I have this feeling of helplessness and lack of agency. I think that was the most challenging aspect of advocating for change, and in the context of accessing innovation, and then try to have that new insight work for me.
Thank you for expressing that. Yes, thank you for putting your hand up, or I think or maybe that was a little glitch in our system. I want to, Dr. Dahar, Dr. Patel, bring you into this conversation. Absolutely 100% challenging to what I call coordinate care. Can you give, share with our audience some of the positive ways that this can and does happen? Clearly, the two of you are doing it. And as a patient, what you should ask for, how you begin to advocate for yourself in terms of this vast concept called inoperability. Dr. Patel, maybe we'll throw it to you first.
Yeah, thank you. And I think we heard some really important concepts raised there. I think our multidisciplinary cancer conferences, MCC, sometimes called multidisciplinary tumor conferences, are really important for us when we're talking about complex cancer care. And that's not just for colorectal cancer. These exist for all complex cancers. These discussions are kind of a way for a patient to be reviewed by 6, 8, 10, 12 specialists to help determine kind of what treatment options should be offered. Some tumor conferences, ours doesn't, but some tumor conferences have patient advocates at them to try to help bring in a patient perspective. We share the discussion of the MCC for our patients, and the documents that we generate from that are freely available to patients. So I think that's important. I also would like to point out, there's a lot evolving. And when we talk about individualized care, precision medicine, et cetera, a lot of time we're talking about systemic treatments. The backbone for treatment for most colorectal cancers still is surgery. And I think it's really important to raise that. I think, especially in a Canadian setting where there's limited resources, we really want to know that when we're offering these targeted testing and panels that can be very expensive, that we're doing it in a way that will help us with the decision making and not muddy the waters too much. And I think that's something that we always struggle with is this expensive test going to help us provide a better treatment option to the patient? Does it provide information that potentially will help us next year or a couple of years from now, or is it something that's available but we don't know what to do with yet? And it can be very confusing for patients as well. So I'm a strong advocate of having all patients reviewed at tumor conferences. I think it allows a patient who can't travel from place to place or continent to continent to get those opinions that they need. Often they're done at a regional level, and often it's with different perspectives, oncologists, surgeons, radiation oncologists. And I think it's really important to get those. And, Dr. Dahar and I have sat on many tumor conferences together. And although they're not contentious, I think it allows people to voice, what about this treatment? What about that treatment? What about this clinical trial? I think that's really important. And definitely, I know Dr. Dahar probably has something to say about clinical trials and being aware of those, because those can be very helpful, but it's also quite hard to keep track of them all and who is eligible, because it can be very restrictive.
Yeah, thank you so much. And so there's two aspects, Dr. Dahar. I just wanted you to close the loop on what I call this issue of interoperability, to close that subject. Who's in charge, and what does a person who's just been diagnosed need to know about that in terms of how they can empower themselves, number one. And then let's bridge into a conversation on what is a clinical trial, because I think many people in our audience are still not fully understanding of what that is.
Thank you for that question. I'll first of all begin by acknowledging Sion's, like her expression of her journey and the challenges. Those are so real. So I go through this on daily basis, and it is quite stressful, and it generates a high amount of anxiety and stress in the patient, in the caregivers, and the family members. Lack of knowledge is the worst thing. Just the fear of unknown, it kind of escalates a lot of unnecessary thoughts and things which can easily be, discussed with your care team and questions. And patients are sort of in that space where they sometimes don't even know what question to ask, right? So I can really sort of feel that where Swing is coming from and how she sort of had to navigate the system. And I think that is one of the very big challenges which our patients face. So I will start by, first of all, addressing your point of inoperability, where who is responsible and what discussions and what patients can ask. So I think I will allude to what Dr. Patel just mentioned. The tumor board discussions are a huge, huge resource. So this is a very valuable place where a patient, specialists from different, areas, they sit together and discuss. And I think majority of the times it is our goal that we discuss and inform this whatever came out of that discussion to our patients at their next visit, because that is where the major decisions have been made, and it is patients' right what we discussed about their case and how this discussion evolved and what eventually the tumor board recommendations were. Those are documented and it is their information. And I think the onus is on either the surgeon or the medical oncologist, whosoever has brought that, a case for discussion. So I think patients should know, and this should be discussed with them. And the point about the clinical trials. So basically, I would say that in very simple terms, clinical trials is sort of a exercise, right? Like it's a research study which involves human participants. So when you do research on human participants, that's what clinical means, and trial is meaning that you are conducting research. It basically means that you are evaluating the safety and or the effects of an intervention which is new and is obviously not a part of standard of care. It is not in practice. And that is what you are trying to see, if that new idea can be brought into practice to improve the health outcomes of patients. And this is it includes many different things. Like it starts from drugs to vaccines to these days the new therapeutics involves like the radio pharmaceutical agents. Those can be tested, and then different biological products and surgical procedures, devices. So it has a huge range when we talk about clinical trials and what all you can
Yes,
test
indeed.
on human participants.
Yes. Is there any specifically in the colorectal cancer space that we'd like to educate our audience on? Certainly one of the new names to many that's been in the literature is fruquintinib.
Frequentinib, yeah.
Yeah, so thank you for correcting me on that. Yes.
So frequentinib is an oral agent. It blocks the vascular endothelial growth factor. Again, a very complicated term. It is a receptor which will block the tumor's blood supply. Just if you want me to explain it in very simple terms. And it has many other roles. So it kind of has a very broad action, which ultimately leads to tumor growth, like control of the tumor growth or multiplication or spread. So basically, frequentinib was also tested in a clinical trial, and it was like a phase 3, meaning where thousands of patients are involved in a research study to test if this drug would be effective in that particular population. And the population for this particular trial where this drug was tested included patients who have failed chemotherapy, who have failed some of the initial combination targeted therapies which are available in the second or third line setting. And then if patient has failed multiple 2 to 3 or even 4 lines, then you could use frequentinib in the later lines. It is now approved, at least here in Alberta, and we are actively prescribing it to our patients in the third or fourth line setting. And it is an oral pill. You take it for 3 weeks in a 4-week time period. And the side effects are there, but obviously if somebody is interested, they should speak to their medical team about it. Yeah.
Thank you for outlining that. So, did you participate at any stage in a clinical trial? Investigate them from your perspective, given your given the extensiveness of your research around
Yes.
diagnosis?
So I am currently involved. I am actively putting patients on clinical trials in my clinic, and it includes different sites. Clinical trial space has evolved significantly in the past decade. So we have agents which were used in later lines, which are being brought up front and in combination with chemotherapy, which remains the standard of care for stage 4 colorectal cancer if they are not MMR deficient. Now, this is one space that in stage 4 disease, that MMR deficiency, that result which is given to a patient at the time of diagnosis, can help make a choice where they could either use immunotherapy if they are deficient versus chemotherapy, which has always been the standard until we had this special testing available. So having said that, this space is bringing targeted therapies in combination with chemotherapy in the first line setting. And GI ASCO 2025, this conference that happened in January, gave us the first interim analysis results of this Breakwater clinical trial, where you are now able to combine chemotherapy with a targeted agent, which is patients with BRAF mutation who were found to be, have this mutation. Now they can have this targeted agent, encorafenib, cetuximab, and chemo in the first line setting. This is right out of this, January conference, new data, survival benefit, and we are just waiting for special access, program by the company. So it's not the clinical trial, at least in our center, has been closed now. So we're looking at having access to this regimen. So things like this is sort of one example how clinical trial space is evolving, and there is a lot happening even in the space where de-escalation of therapy. We just talked about non-operative approaches. So in the right patient, very like not a long time ago, there was that study of use of immunotherapy in a right patient with rectal cancer who we used up front, and they could avoid the surgery because the trial showed significant responses. So again, you have to be able to select the right patient in the right disease setting, in the right stage, with the right kind of information, which will include, precision medicine testing results to be able to access any kind of clinical trial.
Thank you so much for the very detailed explanation. Again, a lot of encouragement that as science and technology is developing in this space, there's room for hopefulness. We only have about 10 minutes left in the session, and I want to go around the panel, and I'll start with you, Dr. Patel, which is if we look 5 years ahead and think about the future of treatment relative to what it is today, what do you think are the most fundamental differences or changes that are on the horizon here for people who have been diagnosed?
Yeah, thank you for that question. I think immunotherapy is quickly gaining traction. I think the clinical trials that Dr. DeHard speaks about, a lot of them are designed for stage 4 patients that have run out of other options. Immunotherapy is really interesting because it can be for patients with much more early stage cancers. About 2/3 of our patients will not have metastatic disease and have curative intent treatments. And immunotherapy trials are opening up for those those stages of disease. And I think 5 years from now, we'll be using much more immunotherapy upfront before any other intervention. So before surgery, before radiation, before other chemotherapy. I think that's what we're going to see. I also think that we'll be looking to try to minimize, from my perspective, trying to minimize the trauma of surgery. So trying to do more minimally invasive surgery, trying to do smaller procedures instead of bigger ones, and trying to avoid surgery altogether. So I certainly see a period of time where, we heard about the coin flip to see if you can avoid operations. It may even be a much higher proportion than that, especially I think in very selected patients. So I think we'll be able to better predict who's going to benefit from this attempt to try to avoid surgery and who would never benefit, and can we avoid different things. So that's where I see things really moving, at least in the patients that I see.
Thank you. And just because I know it's always on people's mind, the role of AI and just, helping us to make these decisions has got to be extraordinary.
I think, it's hard to know where it's going because it's being applied to everything. So can we bring it into the operating room to help us identify anatomy? Can it be applied to radiology? So the MRI and CT scan images, can it be used in a way that can help us decide what that means and interpret it in a different way? Can it be used in pathology reports to identify certain features that maybe we're not even thinking about? What I see AI doing is complementing kind of clinical decision in terms of making it a bit more helpful to know, is this MRI finding true or not? Maybe AI can really discriminate that, as opposed to trying to plan 3 months from now to see if there's been a change or not. So I think it may help us be much more specific. I'm no AI expert, so I'm interested to see where it's going, because there's a lot of hype, but I haven't really seen the applicability yet, at least in what I'm doing. But I'm certain it will be, because it's everywhere. It's on my phone right now telling me what I need to ask Google. So it's going to be everywhere, I'm sure.
Yeah, we can chat GPT this question afterwards, right? Okay. Dr. DeHard, I'd like you to just briefly answer the same question, which is really, what do you think the big advancements in colorectal cancer treatment are going to be in the next 5 years? And then, Soyeen, I want to come back to you and finish up on a specific, very patient-centered question.
Thank you for that question. So what I think that a lot of attention these days is to de-escalate as much as we can. So, for example, I gave you the a brief introductory spiel on stage 2, where we are avoiding use of chemotherapy if the patient is MMR deficient, right? So, and then there are many different trials which are looking at even using immunotherapy upfront, right? And just like how Dr. Patel mentioned, more and more emphasis is to try different combination treatments, chemo targeted therapy, and then a lot of emphasis on even trying to understand how can we make the patient's cancer experience better. And that's what is non-operative approaches. We would never think about these things. I am giving so much of neoadjuvant treatments these days in my clinic, and we are even sending patients with lung and liver metastatic disease for these extensive surgeries, and people are doing well. And that was not the case even 10 years ago, right? So a lot is happening in designing newer approaches. How can we improve the outcomes? So it's multiple different approaches in that space, whether it is use of technology, surgery, diagnostics, therapeutics, combination, de-escalation. So it's a very, very exciting time, and I feel really lucky to be starting my career at this stage where you have to. It can become challenging, but it also adds flavor to your practice. So you always are getting new information. So I think it's an exciting time. Yeah.
Yeah, thank you for that. Such a beautiful summary, and I get such hope out of that kind of summary. So Cheyenne, I want you to close this session because this is a very complicated conversation to have. You've just been diagnosed. We've got brilliance in our medical system. We have all kinds of options, but I, as a person who've just been diagnosed, needs to know what to ask for, what to think about in terms of ensuring that I get my best treatment plan possible. So what, as a patient, should I be asking of my care team? How do I be the best partner I possibly can with my care team?
I think one thing that kind of surfaced throughout our conversation was this genomic testing and the role of genomic profiling to be done up front, and then how the cancer takes a lifetime approach, right? Whether the genomic testing result immediately informing your first line of treatment, to it can help with your ongoing maintenance of your treatment and your cancer as part of your journey. So I think that surfaced throughout. And then I spoke about the impact of more granular characterization of the tumor, understanding my cancer better. So that came up with the genomic testing, molecular testing for cancer in that context. It will be widely adopted. So the sequencing cost is getting cheaper, and underlying data management system is also getting cheaper as well, as we're dealing with the large amount of big data, right? So things like whole genome sequencing. So I believe that's coming, which will have a major impact on the patient's survival as well as the patient's cancer journey, like myself. The other thing we talk about is that the innovation alone, things like genomic testing alone, is not enough. We need interoperability. So in terms of interoperability, information system plays a key role as well. So often you see that the surgeon is in one hospital and then your oncologist in a different organization, even within the same local contact. So organizations sharing data, so all that underlying information systems, and that support is not here today. But I'm happy to share there's a global standards development that's happening at Health Level 7, which is a global standard development body. So things like how we standardize molecular tumor information. So how we actually standardize the reporting on things like haplotype, different genetic variants and annotation, etc. So that's coming as a global standard, soon to be adopted and integrated as part of EHR system, our electronic record system. So I've been very lucky to be exposed as part of that work, and then that development work at Health Level 7. So that's something exciting, and I believe that's going to have a fundamental impact in terms of improving the ability of system, especially emerging modality such as genomics for cancer patient.
Yeah, I think it's extraordinary that you have the lived experience to be able to inform the system that way. So that's a wrap on time. So I wanted to thank Dr. Dahar, Dr. Patel, and Shoyeen. We're available now for another 15 minutes or so to take questions from the audience, and I know that we're going to have many. What a fascinating session, everyone. And it's now your turn to ask questions. And many of you have been submitting questions through the question tab on the platform. We encourage everyone to continue to do so. And I'm going to just start with welcome back Dr. Dahar and Dr. Patel. We're here to answer the very many questions that you have at this stage. So let me start with the very first one. Really to Dr. Patel, to Dr. Dahar, no particular order of who answers what, but is there benefit to asking for some of these targeted tests which have been discussed today after diagnosis? Tina says, I knew nothing of these tests at diagnoses, and I'm actually currently in remission from stage 4. Would she benefit from participation in any of these targeted tests now? Maybe we can start with you, Dr. Dahar.
Yes, thank you very much. So that is an excellent question. So the field of cancer therapeutics has advanced significantly over the past decade, and I can see that some of the patients might feel like, oh, what if I got these tests at that time, and what could have changed in my treatment paradigm? So the answer to this would be that if you are in remission, then obviously it's a great news, and you'll continue to follow up with your surgeon as well as a medical oncologist, whosoever is looking after you during this time. However, unfortunately, if this cancer decides to come back later on, that is when the value of getting the tumor sample recovered from where it is stored right now and subject them to the tests, if at all you are offered treatment, and that will depend upon the type of recurrence or how that cancer presents when it presents. So I think at this stage, since you are in remission, I do not see the value of doing them right now. But yes, your tumor can be tested this date for that. And usually I would say that the medical oncologist would like to have another biopsy for the new recurrence. Yeah.
Right. So the enactment of those tests would be fundamentally through your oncologist.
Well, it depends. Like again, because if the surgeon sees a recurrence, then they can also order the rebiopsy. Because at that stage, depending upon the patient's profile, you might want to contemplate whether it's a new primary versus it's the same recurrence.
Perfect. Yeah. Dr. Patel, did you have any comments you wanted to add to that?
No, I agree with Dr. Dahar on that one. Yeah.
Okay, perfect. Great agreement. I'll move to the next question, which is how can patients get a review of their case done at, we talked about tumor boards and things like that. Tumor conferences is the language that's used in the question. Is this automatic for everyone who's diagnosed? What's the process? How does that work? the whole idea of getting your review of the case on these tumor boards?
Yeah, so I think a lot of societies and Cancer Care Ontario specifically has recommended that all rectal cancers get reviewed at tumor conference. Colon cancers tend to be a bit more straightforward, at least in the initial diagnosis. So they would be reviewed more on a case-by-case basis based on complexity. At our hospital in Kingston, we review every rectal cancer case at tumor conference. So it's automatic for our patients. Will your case get reviewed if you make a request from your physician? It may or may not. It depends on what the clinical question is. Usually we bring patients to tumor conference when there's a question about the radiologic findings, whether sometimes there's a couple different options and we're not quite sure what would be the best course. And there's also a lot of informal discussion that kind of mimics tumor conference behind the scenes. So for instance, Dr. Dahar and her colleagues considering chemotherapy, I know they often have a lot of discussion and dialogue, what's best for this patient for this reason, even if it's not in a formal review. Dr.
Dahar, did you want to add to that?
I think I concur every bit what Dr. Patel has mentioned here. So this definitely can be instigated at different levels of care, how the need is at that point, or what specific question do we want to address.
Great. Now tell me, is there differences by province or even regional health authorities, or is there consistency in any?
So I think the review at tumor conference, largely there's agreement that complicated and complex cancer patients should be reviewed at tumor conference. The ultimate outcome may be different. It may be dependent on the expertise locally. It may be dependent on how a patient's biology is, what their findings are, what previous treatments they've had. So the outcomes of these tumor conferences can be sometimes unpredictable in that we may not have a standard of care, and the whole purpose is to kind of think outside the box, understand what trials potentially someone would be eligible for, and really try to tailor the treatment options to the patient to try to ensure that we have the best outcome for them.
I think that's a great springboard to the next question here, and it's one of my favorite subjects, is how does one actually get considered for or even know about a clinical trial?
This is tough. There are lots of clinical trials. Some are opened at some hospitals, but not others. Generally, the cancer center has on their website which trials are enrolling at that cancer center, and the oncologists, especially the medical and the radiation oncologists, seem to have a very good understanding of where trials are open and whether a patient is eligible. And it's not unusual for us to send patients elsewhere if we know that there's a trial open that we think the patient could potentially benefit from. But it is tough, and I can't say that I know of every trial that's open in my own center, let alone across the country. So it can be very tough. Patients can certainly advocate for trials that they're aware of, but again, it can be very tough to navigate that. But we do try our best to allow patients to enroll in clinical trials, which are a very important part of what we do.
Yes, I'll add, and of course, Dr. Dahar, give you a chance to answer that because I know we had chat about it in the session itself, but I always want to suggest that folks reach out to Colorectal Cancer Canada specifically for guidance in this area. They're very, very on top of and aware of many of the trials going on, not just in Canada, but in other parts of the world. Dr. Dahar, anything you wanted to add at this stage?
I think just like how Dr. Patel mentioned, for any one of us, like if a trial is open at a site, it is definitely a primary thing that we would want to screen the patient, and if they are eligible, that patient is generally majority of the time offered an opportunity to go on the trial. So it has happened when I was practicing in Ontario, and now it's the same practice, even like I do that. So clinical trials are one of the treatment options. So we always tell that, like once we are, offering systemic therapy, that 1, 2, 3, like how you go by, these are the options, and comfort care sometimes, depending upon where they are at in their journey for cancer treatment, is offered, just like how there's opportunity for trials as a part of the treatment.
Yeah. Thank you for that. I'm going to go to the next question, which is, have there been any advancements in making immunotherapy work for people whose tumors are not MSI high?
I can speak about that. So far, the studies have shown that the patients who are most likely to benefit from the immunotherapy are the ones who have the MSI high. Their tumors are found to be MSI high, like having that defect. And if the question is whether anything else beyond immunotherapy has happened in the patient, in the subgroup of patients who are not found to have MSI high tumors, yes, we have like targeted therapies and other forms which are kind of being brought up front in the first line setting. For example, this very recent study with BRAF mutant patients, now we are adding, targeted therapy along with chemo to help these patients. So they are not MSI high, but there is evidence that if you use immunotherapy in patients who are not MSI high, you can even harm them. So, generally speaking, you only target immunotherapy in patients who have MSI high tumors. But there are a lot of advancements happening for the other patient population.
Indeed. Yeah. Dr. Patel, any comments around that yourself?
No, I do agree that this has been such a revolutionary change in colorectal cancer treatment. So I think immunotherapy, I think they're exploring it not just in very specific patient groups, but to see who else would benefit. So,
okay. Because we're talking about future advancement, this is a very interesting question. And the question is, would you be able to tell us a bit more about the use of aspirin and which patients would benefit most from its use? Trick
yeah.
question.
So,
Yeah,
I see it from our good friend Barry asking the question.
Yeah,
he
I
probably
know.
already knows the answer. I know that I believe a large study was just presented at ASCO this year, ASCO GI, looking at aspirin as a means to reduce the risk of recurrence. I think it did show benefit. So I'm not that familiar with this literature. Maybe Dr. Dahar is a bit more than me, but it seems like a very promising intervention, very cheap, readily available. A lot of our patients are on aspirin anyway. So I don't know, Dr. Dahar, if this is something that's more on your awareness.
I can elaborate on that, Dr. Patel. So this trial, it's called Alaska trial, was presented at the ASCO GI earlier this year, as you mentioned. It has showed that if a subset of population which tend to have PIK3CA mutation, so they are specific set of patients whose tumors have this mutation that is obviously picked up on this initial testing, which is pretty much standard, and PIK3 is sort of reported on those samples these days, but not all the PIK3 mutation kinds. So there are caveats to that. And then if you're interested, you can talk to your medical oncologist more about it. So very specific subset of patients whose tumors are found to have these mutations. This trial subjected them to a particular dose of aspirin for 3 years, and it was found to reduce the chances of recurrence in this population who got the aspirin by about 50%. So it was quite a good trial. Like it got a lot of attraction, and we are at our center also looking at like whether this is practice changing or how we can sort of promote, you could say, more specific PIK3CA testing, which we need some specific set of mutations that need to be reported for the use of aspirin. So there is strong data, there is obvious benefit, but whether we are actively going to utilize it in our practice is still an area of debate, but we are definitely talking about that these days.
Right, thank you. And I'm incredibly impressed that you would know about that study, of course, given your work and your commitment to this. Thank you for that very much. And the next question relates to genomic testing and where and how people might be able to access. This one specifically talks about Toronto. Neither of you are from Toronto, but how generally would people go about finding where and how to get genomic testing?
So
Does that come directly from the oncologist?
So I think genomic testing. There's obviously genetic mutations that are associated with development of colorectal cancer. Some are somewhat apparent based on the tumor biopsy or the final specimen, and it's almost reactive. So there's some signs that we see in that specimen that would allow us to say that this patient would benefit from genetic testing. So it's selective. I'm not sure if routine genetic testing would be offered or it could be requested. I'm not sure if Dr. Dahar has a different perspective on that, but it tends to be very selective.
Yes. So regarding I think what this the question is about, like the NGS, the next generation sequencing, which we tend to order in a very, it depends from patient to patient and when do we want to order it. Generally speaking, the very limited amount of testing, like we get BRAF, KRAS, and all of those testing done upfront as a standard of care. But once the patient sort of failed the initial lines of therapy, we start looking at any other targetable, mutation. So, for example, NTRK, even though it's very, very rare, but these days we can ask for it. Some centers are able to do it, but then patients have the liberty to work with their medical oncologist, and depending upon which center works with which company, it can be ordered. So Foundation One is, for example, a very common example where I was working in Kingston. So we used to send it to them for testing. But then whenever it's needed, at what stage that extended testing is needed, your medical oncologist will be, talking to you before that, because it's patient. Your patient has to pay for it, like it's paid from pocket.
Yes, yeah,
it's not covered. So I would imagine that you would get that information when that is needed in your particular case.
Yeah, and just to build on that again, a wonderful resource is Colorectal Cancer Canada. They have run webinars. They have folks to talk to regarding this subject. So if you feel that you're uncertain or you need some guidance, please do reach out to Colorectal Cancer Canada. And we are at time, even though we still have dozens of other questions. We're very grateful to you, Dr. Dahar, and you, Dr. Patel, for coming back. Thank you so much on behalf of Colorectal Cancer Canada for being with us today. We're very, very grateful for your participation. And with that said, I'd like to thank our friend and sponsor, which is Pfizer Canada.